Okay, today's lecture is about pediatric resuscitation. This is one of the more stressful situations that any pre-hospital provider or other healthcare provider can find themselves faced with. And if you stay in EMS long enough, you will be forced to confront how to deal with a seriously ill or injured child at some point. So that's where we're going to start today. Pediatric cardiac arrest is usually secondary to another event. And in most cases, it's secondary to respiratory failure or respiratory arrest. Now, that respiratory failure or respiratory arrest can be secondary to another condition that has caused the respiratory failure, whether it be a respiratory emergency, maybe a cervical spine injury paralyzing the nerve pathways that feed into the chest wall so that the child can adequately breathe, maybe due to respiratory depression from some sort of an overdose like opioids, etc. So there may be something that has precipitated the respiratory failure arrest, but when we look at the reason for the cardiac arrest, the primary reason, more often than not, it is related to an issue with hypoxemia, hypercarbia, and/or a combination of both. So that means that in cardiac arrest, the most important interventions besides maybe recognition of the emergency and hopefully keeping it from deteriorating to cardiac arrest is adequate oxygenation to achieve normoxemic levels, 92 to 95% or 99% O2 sat, and ventilation if it's indicated. Basic life support measures airway, airway, airway. We typically use a head tilt, chin lift type method for all of our patients. It's a little more controlled with the big tongue that's associated with pediatric patients with more forward jaw displacement with the jaw thrust. That's critical, while avoiding extreme hyperextension of the neck, because the airway itself is very flexible and pliable, and hyperextension can actually also cause airway compromise by, I guess, a simplification, a gross simplification, kinking the airway, but that's really not it, but you get the idea. With a possible neck injury, though, you may have to leave off the head tilt portion of the procedure and just do the jaw thrust or chin lift. And remember that the head is typically larger in pediatric patients, especially the smaller they get, and this will cause the neck and the head to flex forward when they're lying flat. That's why it's so important to consider padding up underneath the shoulders so that you can get everything in a neutral alignment, and that will open the airway as well. Breathing, look, listen, and feel as normal. Limit to the volume causing chest rise when you are ventilating with a bag valve mask device. Children are sometimes underventilated because the airway just isn't open, so you get a lot of blow-by or pop-off valve. But it's also, again, necessary to avoid excessive ventilation and excessive hyperextension of the neck, but excessive ventilation too forceful, too fast. Use the bag valve mask device only if it's proficient, and you're in paramedic school or AEMT school here, so that means that you should be proficient. Practice makes perfect. Also continuing practice. A two-person technique may be best to try to ensure that the airway stays sealed, or the mask stays sealed around the nose and the mouth, and that the airway is opened and maintains open enough so that when you press that bag, the chest goes up. Most pediatric BVMs, the child size, should not typically have pop-off valves. If they do, and high pressure continues to having that popping off, just tape it shut. Do not use any sort of a positive pressure device on children, such as a demand valve, because you can cause a lot of barotrauma. This doesn't preclude you from using CPAP or BiPAP when it's appropriate and used appropriately, but some of the other positive pressure mechanical devices may be a problem. Ventilators have to be set at the appropriate setting so as not to over ventilate the lungs in pediatric devices or pediatric patients. Ventilate your infants and children every 3 to 5 seconds if they're not intubated and they require ventilatory support. If they're intubated, go to once every 6 seconds. Circulation checkpoints, infants, the brachial artery. Older children, you can use the carotid artery like an adult, but with an infant, it's, 1 year of age or below, it's very hard to get in there and adequately assess the carotid pulse, especially without causing respiratory compromise by accidentally compressing the airways when you're trying to feel for a pulse. Circulation techniques for CPR, you can do the 2 fingers on the breastbone, 1 finger width below the nipple line, depth about greater than 1/3 of anterior posterior diameter of the chest, and you suppress at least 100 a minute up to 120 per minute. Or you can encircle the chest wall with your hands and use your thumbs. Either way it goes, good compressions are mandatory for the survival of the child, so make sure that you're also not just going the appropriate rate, not just going the appropriate depth, but that you're also consider using 2 rescue CPR so that you can switch every 2 minutes to keep people from getting tired, in your compression depth and rate starting to suffer so that the patient doesn't keep adequate flow going through the cardiovascular system. If it's 2 rescue, it's 15 compressions for every 2 ventilations. 1 rescue, it's 30 compressions for every 2 ventilations. Or if they're intubated, 1 breath every 6 seconds. But the one thing I will point out to you is do not waste time looking for the bag valve mask device or barrier device when you should be doing chest compressions. Do continuous chest compressions until you can add in ventilations if needed. The best sign of effective ventilation is chest rise. If the chest is not going up and down, then the oxygenated air is not getting into the alveoli so that it can diffuse into the blood vessels, and so that carbon dioxide cannot be effectively exhaled out. Make sure when you're doing chest compressions too that you allow adequate recoil of the chest to allow for the ventilations to go in and for the breaths to go out. Best sign of effective circulation is a pulse with each compression. Oxygen therapy, again, initiated as soon as possible, but do not delay chest compressions while you're getting out a BVM or oxygen. Do chest compressions until the BVM or mouth barrier device, if you're using one, is available. Use high flow oxygen during the arrest phase. But after the child is resuscitated, target your oxygenation to achieve SaO2 of 92 to 99%. Use a humidifier if at all possible. I know that's harder on arrest, but post-arrest that's even more important. This will help keep the airways from drying and plugging and creating even more issues. Also use smaller tubes or the appropriate size tube, and use other airway adjuncts. If the child has altered mental status or is comatose, using an appropriately sized nasal airway or oral airway is very beneficial when trying to keep an airway open. It's very difficult sometimes to decide quickly in a critical situation what is the best size of something or the best dosage of medication to administer to a pediatric patient, because a 2-year-old is going to need different equipment or dosages than a 6-year-old than a 12-year-old. So consider using a length-based resuscitation tape or some other helpful devices that are out there to help you make quick selections and also to keep you from making size and dosing errors. Endotracheal intubation. The need to intubate is not the same as the need to ventilate. And in fact, many states don't allow pediatric intubation anymore. Ventilation without intubation may be preferred in some settings. And if the child is going to be intubated, you need to be good at it. You need to be able to intubate. You need to have plenty of practice, and you need to keep the practice up, because it's very, very easy to cause further harm by choosing incorrect equipment or using the equipment inappropriately in those tiny, very fragile airways. Proper tube size is imperative when setting up to intubate the pediatric patient. There's different tools out there there are different tools out there to choose size, but here is one that that a lot of people use. Looking at the child's little finger and putting the end of the tube to the child's little finger in the same diameter. A formula that is very common and that you should know for National Registry, American Heart Association, and memorize for use for yourself is in children greater than 1 year old. It's their age plus 16, and then divide that by 4 will get you the proper tube size. Otherwise, use a length-based resuscitation tape. Children less than 8 years old have a smaller tracheal diameter and a narrow cricoid ring. Most protocols still call for uncuffed tubes in these children. However, the latest version of the American Heart Association guidelines and research shows that it really doesn't make that much difference in ICU settings or other controlled settings. They used to think that the cuffed tubes would put too much pressure inside the airway, and that may or may not be the case. If you cannot get a good seal with an uncuffed tube where there's not a lot of leakage going on, if there is a lot of leakage going on around the tube, then you can consider going to a larger size tube or just using a cuffed tube of the same size. Infants and small children have a very narrow, soft epiglottis that is very anterior in the airway or in the neck. So we usually, in infants and small children, find it easier to intubate by using a straight blade to visualize the vocal cords. These are examples of pediatric uncuffed endotracheal tubes in small sizes. Any attempt that you're using per National Registry should not exceed 30 seconds, or any time the patient is without ventilation for 30 seconds or more is a critical failure. In the real world, and what we should be doing is paying attention to our monitors. Our child that we're attempting to intubate should be hooked up on a cardiac monitor if you're a paramedic, should be on an O2 sat machine if it is reading, if they're not so critically impaired with perfusion that the O2 sat is not reading. And you should be using an end-tidal CO2, nasal end-tidal CO2. If you're monitoring and you've got someone that's watching these devices while you're attempting to intubate and the child starts to bradycardia down or brady down, O2 sat drops significantly to dangerous levels, or CO2 sharply rises, then you need to stop the intubation attempt and ventilate and oxygenate. And then when you stabilize the child, you can try again. Do not allow the child to suffer severe hypoxemia, severe hypercarbia, or bradycardia just because you can't get the tube and you want to continue trying. If you use passive oxygenation and pre-oxygenate the patient before you attempt the intubation, in many cases you may have longer than 30 seconds to do the skill. You just have to watch the machines and the monitors. Avoid hyperextension of the airway during ventilation or intubation. The sniffing position is preferred, and keep something under the child's shoulders during the procedure will help put everything in an inline so that you can see the epiglottis, the glottic opening, etc. Lift up on the blade, do not pry back. Even if they don't have teeth that you can see, you can cause damage to the underlying teeth and the gums, and you can cause damage to the very soft tissues overlying those teeth and cause severe bleeding into the airway. So do not pry back, lift up. See how they're holding the laryngoscope here? It's in children, it doesn't require a lot of force or stress. It's more where you position the blade and how you walk the blade down and pick up and pull up gently to be able to see where you need to insert the tip of the tube. Once you get the tube in and you can see the little black line where it needs to be in the airway, confirm placement. The best way, most definitive way, is by end-tidal CO2 in the exhaled air. So immediately put that end-tidal CO2 device on the tube and you should be able to see rising waveforms. Seeing the tube go through the cords is all well and good, but sometimes when you go to pull the blade out, that little tube, you can pull it. So that's why, again, end-tidal CO2 is probably the most definitive. You can document when you saw it go through the cords. Document chest rise when you're giving the ventilations. Listen to breath sounds over the sides of the chest wall for a pediatric patient. And you should not usually have sounds over the epigastrium, although there have been some research studies that have shown that even in a perfectly intubated patient with a cuff tube, you may still have belly sounds. Again, that's why ETCO2 is probably the most definitive. Now, I understand if it's a cardiac arrest, you're not going to get much there. So then you're going to go more with chest rise, making sure you have equal breath sounds and those type of things. But remember, if they have any perfusion at all, ETCO2 is probably your best choice. Mark the tube at the corner of the mouth. That way you can see if it accidentally gets moved down too far or withdrawn some. It takes a very, very little bit of movement to impair the airway, especially in a child. And also to help keep from dislodging the tube, avoid excessive head movement. Consider putting a C-collar on them and taping the head down and making sure the kid is secured head to toe so that nothing can move. Frequently reassess breath sounds and watch the ETCO2 in pulse oximetry and EKG. Ventilate to watch general chest rise. Endotracheal intubation drug administration is not the norm anymore, but it's still in the American Heart Association guidelines as a possibility if you do not have an IV or intraosseous access. If you choose to use the ET tube to administer epinephrine, the dose is different. Normal dose is 0.01 mg per kg. If you're going to give epinephrine by endotracheal tube, it's 0.1 milligrams per kilogram. And obtain IV or IVO as quickly as possible so that all other medications can be given through those routes. Cricothyrotomy can be considered if ventilations cannot be adequately maintained with manual means and you can't put in an ET tube. However, surgical cricothyrotomy is not indicated in children less than 12 years old. Needle cricothyrotomy may be an option depending upon your protocol. The narrowing of the tracheocricoid ring makes the surgical route hazardous for the smaller patients, and another access technique should be considered. Vascular access is used in pediatric patients for the very same reasons we use it in adults. Basically, pharmacological interventions and fluid intervention. Scalp veins really have no value for placement in a cardiac arrest situation because they shut down in cardiac arrest, just like the most peripheral capillary beds and smaller vessels in the peripheries. But if you're using it for maintenance fluids or drug route in children less than 1 year old and other routes such as IV&O are not feasible or available, then a scalp vein route can be established. Supplies needed, here's your list. A rubber band for a tourniquet to use around the skull, a 21 or a 23 gauge butterfly. Make sure you attach a syringe with saline and flush the needle and the line before inserting it into the patient. Point the needle in the direction of blood flow always. Leave the syringe attached, and once you think you're in place, inject about a cc of saline to make sure that you're in the vein. There's no signs of infiltration. If there's signs of infiltration, you're not in the vein. Here's an example of what it should look like. Oh, and once it's in place, make sure you pad and tape thoroughly so that it will not be easily dislodged. Hand, arm, foot veins for smaller children, usually 22 gauge catheters. Once you get into the larger children, then you can use 20 gauge. A much larger child, you might even can get an 18 gauge in. Restrain the extremity before attempting to cannulate it if you can, and make sure you flush the needle just like you would with a scalp vein each time to make sure that you have not infiltrated. External jugular routes should only be used in life-threatening situations only with a 22 gauge catheter for the smaller kids. Wrap the kid up in a sheet or something to keep them from moving. Extend the head over the end of a table or the end of the stretcher and rotate 90 degrees. If you perforate the vein, don't go to the other side because the swelling can be enough if you do both sides and blow both sides to cause a hematoma on both sides of the trachea and airway obstruction. Fluid overload. Avoid using bags over 250 cc's in small children. That way you can keep track of how much fluid that you're giving. Use mini drip sets for small pediatric patients or volutrols to help regulate the amount of fluid that you're giving to very small children and babies. You don't need mini drips or volutrols in larger children, but you still want to pay attention to how much fluid that you're giving a child. Fluid resuscitation in kids is typically 20 cc's per kilogram boluses. Reassess. Intraosseous cannulation. IO involves placement of a cannula into the long bone, into the intramedullary canal, where the bone marrow is located. And once you get in there, you can give IV fluids, although you may have to have a pressure infuser to help push the fluids. But any medication that you can give IV, you can give through the intraosseous route. This is an easy IO drill on the left, which has become very, very popular in both children and adults for placement of an IO catheter or needle. The one on the right is a manual device, and there's different versions out there. Indication: when vascular access is required and peripheral sites cannot be obtained in either 2 attempts or about a minute and a half. Now, when we say vascular access is required, this means the kid is either in arrest or spiraling down the tubes toward arrest. A lot of times in adults, we will establish an IV in situations where maybe it would be better to wait till the child gets to the hospital, or maybe they won't need one at all, because in a child that is still alert and oriented, placing an intraosseous needle is extremely painful for them. So IO should be reserved for the children that are circling the drain, down the drain, and you need an IV and can't get it quickly. Devices that can be used: 16 gauge hypodermic needle, spinal needle with a stylet, bone marrow needles, and then there are other automatic devices that are out there, like an Easy IO, Big Gun, Ping, things like that. The site for pediatrics is typically the anterior tibia, 1 to 3 centimeters below the knee, just medial to the tibial tuberosity. Usually 1 finger's breadth below the tibial tuberosity and just medial. Okay? Contraindications: fractures of the same limb, osteogenesis imperfecta history, osteoporosis history, or if you already tried to do it in that bone and you didn't get it, go to the other one. The needle is in place if there is a lack of resistance when you go to flush, or a lack of substantial resistance when you go to flush with your saline in the 10 cc syringe. If it stands without support, if you aspirate, you might see bone marrow flowing up into the saline that's in your syringe, but not necessarily, or the infusion flows freely. Now, I will tell you that sometimes when you place the needle can become clogged with blown. That's why it is really important to make sure you have a 10 cc saline flush syringe handy, because the first step should be, when you think you're in place, is to flush it and make sure that you can get fluid in and make sure that it is not infiltrating around the site. Now, I have a little video here to show you for the Easy IO since it's so popular. So let me play that for you, and now watch this.
Critical judgment should be used to determine appropriate needle set selection based on patient weight, anatomy, and tissue depth overlying the insertion site. To facilitate selection of the correct length needle set, tissue depth over the insertion site should be assessed prior to selection of the needle set. Press your thumb or finger over the insertion site to estimate the depth of soft tissue. With the needle set tip touching the bone, the 5 mm mark must be visible above the skin for confirmation of adequate needle set length prior to drilling. If the needle set is inserted through the soft tissue and does not reach the bone, or the 5 mm mark is not visible above the skin with the tip of the needle set touching the bone, the needle set is too short. A longer needle set or alternate site should be chosen prior to penetration of the bone cortex. Using a needle set that is too short will increase the risk of catheter dislodgement, leading to extravasation, create a hole in the bone unnecessarily, and render the site unusable for future IO access for a minimum of 48 hours. Appropriate needle selection as evidenced by the black 5 mm mark visible above the skin when the tip of the needle set is touching the bone prior to drilling. Extend the leg. Prepare the site by using antiseptic of your choice. Use a clean, no-touch technique. Insertion site is approximately 1 cm medial to the tibial tuberosity, or just below the patella, approximately 1 cm, and slightly medial, approximately 1 cm, along the flat aspect of the tibia. Pinch the tibia between your fingers to identify the center of the medial and lateral borders. Remove the needle set cap. Stabilize the extremity. Aim the needle set at a 90-degree angle to center of the bone. Push the needle set tip through the skin until the tip rests against the bone. The 5 mm mark must be visible above the skin for confirmation of adequate needle set length prior to drilling. Gently drill. Immediately release the trigger when you feel the pop or give as the needle set enters the medullary space. Avoid recoil. Do not pull back on the driver when releasing the trigger. Hold the hub in place and pull the driver straight off. Continue to hold the hub while twisting the stylet off the hub with counterclockwise rotations. The catheter should feel firmly seated in the bone. Place the stylet in a sharps container. Place the easy stabilizer dressing over the hub. Attach a primed Easy Connect extension set to the hub. Firmly secure by twisting clockwise. Pull the tabs off the dressing to expose the adhesive, then apply to the skin. Aspirate for blood, bone marrow. Inability to withdraw aspirate blood from the catheter hub does not mean the insertion was unsuccessful. Consider attempting to aspirate after the flush. Site placement can also be confirmed by ability to administer pressurized fluids and noting the pharmacologic effects of medication administration after flow is established. Flush the catheter with 2 to 5 milliliters of normal saline. For patients responsive to pain, please visit www.easyIOcomfort.com for additional information. Connect fluids if ordered. Infusion may need to be pressurized to achieve desired rate. Assess frequently for any signs of infiltration, extravasation, or other complications. Compartment syndrome is a serious complication that can result from unrecognized infiltration, extravasation. Remove extension set and dressing. Stabilize catheter hub and attach a Luralock syringe to the hub. Maintaining axial alignment, twist clockwise and pull straight out. Do not rock the syringe. Dispose of catheter with syringe attached into sharps container.
Okay. That's a very good video. If you have any further questions, make sure when you go to your skills labs that you keep a list and talk to your instructor when you're practicing this procedure. What can be put through an IO? As we mentioned earlier, anything that can go through an IV can go through an IO. Glucose, epinephrine, atropine, vasopressors, whatever. Now let's move on to other procedures. Defibrillation. 90% of pediatric cardiac arrest is asystolic or bradycardic PEA. So defibrillation in the pediatric patient is extremely rare unless they have been going on for quite a while, or have had some pharmacological agents that they've come in contact with that are toxicological situations, or have an underlying cardiac disease or disorder. So defibrillation is seldom needed, but that means you need to know when to use it and how. Pediatric ventricular fibrillation suggests usually one of these three things. Either there's an electrolyte imbalance of some sort. Again, they've ingested some type of a drug or a medication that is toxic, or possibly electrical injury. Most of us now use pads, but I have it as pad or paddle. Infants, the size of the pad is usually 4.5 centimeters. Children, 8. Basically, you're going to use the largest set that contacts the entire chest wall without touching. And if you don't have pediatric paddles or pads, you can use adult paddles or pads with an anterior-posterior placement. Energy settings for defibrillation in the pediatric patient. The first shock is at 2 joules per kilogram. All subsequent shocks should be at 4 joules per kilogram. Cardioversion, only if there's signs of decreased perfusion. So you would have something like ventricular tachycardia, and they have signs that are consistent with decreased perfusion, which means they're going, like that term earlier, circling the drain. If you have to do synchronized cardioversion, the energy settings are, for the first dose is 0.5 to 1 joule per kilogram. All subsequent doses for synchronized cardioversion are at 2 joules per kilogram. Narrow complex tachycardias that are at a heart rate less than 200 is typically sinus tachycardia in the pediatric patient. So look for what's causing the sinus tachycardia. Look for an underlying treatable cause. And we typically do not cardiovert these. You find and treat an underlying cause instead. If you're not sure, then you can consider fluid boluses, especially if they're hypotensive, but if they're not hypotensive, use that with caution. We'll discuss that a little more later. Narrow complex tachycardias at a rate over 230, and these numbers are important, below 200, greater than 230. If it's above 230, it's usually some sort of a supraventricular tachycardia, frequently associated with some sort of a congenital conduction abnormality. These are the ones you're typically going to cardiovert. If they're hemodynamically stable, transport them, watch them. Maintain normoxemic oxygen levels, get them someplace that has the ability to handle this sort of situation. You may consider adenosine, However, if they're hemodynamically unstable, like I said, they're circling the drain, their perfusion status is impaired, cardiovert. And if they do not convert after 2 synchronized cardioversion shocks, consider the possibility that it's sinus tachycardia just really fast. Start looking for underlying causes to treat. Transcutaneous pacing may be indicated in a compromised bradycardic patient, especially if they are unresponsive to pharmacological interventions. Using the appropriate pad size is highly important. It's probably better to use an anterior-posterior placement, but make sure when you place the anterior pad you keep it up away from the diaphragm, because the shocks can cause the diaphragm to spasm and contract abnormally, which then will impair their ability to breathe. Procedure is pretty much the same. for the pediatric patient for instituting TCP as it is for adults, but their skin is a lot more fragile, so burns are more common. But that shouldn't stop you if it's indicated. Drug therapy for asystole, bradycardia, bradycardic PEA, epinephrine is usually the first line. It stimulates electrical mechanical activity. Dosage for arrest or bradycardia in bolus doses is typically 0.01 milligrams per kilogram of a 1 to 10,000 solution IV or IO. It's imperative you know this by heart. 0.01 mg per kg, 1 to 10,000 IV or IO for the pediatric patient. If you're having trouble getting an ET tube and there's going to be, an IV, and there's going to be a delay in IO, and you're in an arrest situation, you can give it ET if you have that at 0.1 milligrams per kilogram, 1 to 1,000 solution. Back it down. Get an IV or an IO as soon as possible for the subsequent doses. You may also use epinephrine for IV piggyback drip and those doses for vasopressor support. Atropine can be used in bradycardic situations with increased vagal tone or primary AV block. The dosage is 0.02 milligrams per kilogram IV or IO. If you have to put it down the tube, it's double the dose. Minimum dose is 0.1 milligrams to avoid paradoxical bradycardias. The maximum single dose for a child is 0.5 milligrams. For an adolescent is 1 milligram. They used to say you would pre-treat any intubation for pediatric patients with atropine. That is no longer considered to be something that is appropriate. If your protocol still goes for that, I don't believe there is a minimum dose like there is for using an IV and IO, but it's not recommended. Remember that most bradycardias will respond first to oxygen and ventilation. Drugs are if the other methods do not work. And for bradycardia that's secondary to hypoxia, ischemic hypoxia, the preferred first drug is epinephrine in pediatric patients, not atropine. Bradycardia non-responsive to epinephrine and then atropine, then you can consider transcutaneous pacing. Treatable causes and therapies. We talked about earlier on in this presentation that respiratory compromise or arrest is a primary cause of pre-arrest or cardiac arrest in pediatric patients. But over the next few minutes, we're going to talk about other ones. And you should evaluate each pediatric patient that has a pulse, but looks sick. You know, we think in terms of sick, not sick. If they look sick, there's a scoring method known as PEWS that you're going to look at to determine if or to what level you need to add oxygenation, IV fluid support, pharmacological support, etc. Just help you to determine just how critical the pre-arrest or sick kid might be. Severe sepsis. Pediatric patients suffering from severe sepsis can deteriorate into cardiac arrest very, very quickly. Okay, and so they may have a history of being sick and getting more and more sick, maybe a history of some antibiotics, and you become suspicious based on their presentation that they are septic or could be septic. The first thing is oxygenation to maintain the normoxemic range of 92 to 99% is imperative. All right, if they're not arrested yet, look at their O2 sats. Hopefully they're perfusing well enough for you to do that. Look at their CO2, as well, to make sure that they're not retaining a lot of carbon dioxide. But the big thing here is getting them into a normoxemic level if you can. An IV fluid bolus, if they're in shock, of 20 milliliters per kilogram can be done and reassess to see if you get success with that and improve their condition, and use additional boluses and reassess if needed. But if they're not in shock, they're febrile but they're not in shock, Fluid boluses may increase mortality and should be used with caution per the latest research. Early assisted ventilation for severe sepsis is a good strategy. If you need to use pharmacologically assisted intubation, etomidate may not be a good choice in severe sepsis patients because of possible adrenal suppression. And there has been some research that indicates that it can lead or may lead to increased mortality rates in these patients. Use another option. Hypovolemic shock. Isotonic crystalloids are fine, like Theta ringers, normal saline in the pre-hospital environment. 20 milliliter per kilogram boluses, but reassess after each bolus. Do not over fluid hydrate them. Reassess their heart rate, their skin, their blood pressure if you can, their lungs after every dose. Intubate if indicated. Consider PAI with other agents again other than etomidate for the same reasons we just discussed for sepsis. Toxicological emergencies. You can have that be the reason or a concomitant reason for the child to be in cardiac arrest. Following slides will address some specific toxicological emergencies and management parameters over and above the outlined American Heart Association arrest guidelines. Cocaine can cause acute coronary syndrome. They can become very hyperthermic. If they are hyperthermic, treat it aggressively. If they are showing signs of ACS, chest pain, etc., consider nitroglycerin drip, and consider administering benzodiazepines such as diazepam or midazolam, Valium or Versed for severe agitation or seizures. In a cocaine toxicological emergency in pediatric patients, do not administer beta blockers. And if they are in refractory cardiac arrest, you can consider giving them a dose of sodium bicarbonate if they are refractory and in ventricular arrhythmias. Tricyclic antidepressants. If there's a cardiac arrest with patients who have ingested tricyclics, do not administer amiodarone or procatamide, as they can make the cardiotoxicity from the tricyclics even worse. So lidocaine would be a good choice, but not amiodarone or procatamide. Post-arrest fluid boluses may be attempted if indicated for low blood pressure. If that doesn't work, or if their lungs are wet, epinephrine or norepinephrine may be more effective than dopamine for the vasopressor in this case. Calcium channel blockers overdose. Treat mild hypotension with smaller fluid boluses than you would in the normal setting, 5 to 10 milliliters per kilogram, because they are calcium channel blocker overdose patients do not tolerate larger volumes of fluid very well. You may give 20 milliliters per kilogram of 10% calcium chloride through a patent peripheral IV line. It has to be patent. Cannot be, it can, risk for extravasation. It'll cause severe tissue compromise. For bradycardia or hypotension, epinephrine, norepinephrine again is preferred over dopamine. Consider high-dose epi infusions in beta blocker overdoses. Beta blocker overdoses, we can give glucagon 5 to 10 milligrams over several minutes and then follow with an infusion of 1 to 5 milligrams an hour. And we may even consider calcium chloride if the other two treatments are not in your protocol or are ineffective and the arrest is refractory. Opioid overdose. Oxygenation and ventilation are the mainstay, and they're the primary in treatment. Worry about the airway first if they have an opioid overdose. Then you can worry about giving them naloxone once you get the airway under control and the oxygenation and move the carbon dioxide out. If the patient has a long-term addiction, which in our pediatric patients is probably more, they were born addicted, and or there's some reason, maybe they're gotten involved in it somehow as a younger, well, heck, even our school-age children now are getting hold of this stuff. So I guess even your school-age children can have a long-term addiction to opioids now. But if it's a long-term addiction is suspected, Naloxone could cause seizures, increases in heart rate or blood pressure, and could even cause acute pulmonary edema. That doesn't necessarily mean not use it. It may mean you need to use it at lower doses or consider an IM dose if they're in a non-arrest state. We mentioned earlier the assessment of the sick kid. Kid looks sick. The scoring is known as PEWS, Pediatric Early Warning Sign Scoring, and research seems to indicate this is a very helpful tool for healthcare providers to help determine sick, not sick. Just how sick are they? Do I need to do something? So you're going to evaluate each pediatric patient who looks sick, non-arrest, because if they're in arrest, or you take one look and it looks like they're going to code any minute, that's kind of, a dead giveaway. But in the kid that just looks sick, using this to determine if you need oxygenation, IV fluid support, other pharmacological support is very helpful. Here's the chart, and you can go online and do a search for PEWS, or Pediatric Early Warning Score, to get a copy of this. But you can see it's a 0, 1, 2, 3 score. Looks real similar to scoring for an APGAR chart. Behavior, playing appropriate, is 0. They're pink. Capillary refill's good, it's a 0. Respiratory rates within normal parameters and no retractions of the chest wall. No seesaw breathing, anything like that. Those are 0s. Behavior, they're sleeping and really not easily awakened, or you have to wake them up when strangers are there. They should be awake. That would be a 1. Pale or dusky, or the capillary refill is delayed, would be a 1. Respiratory rate, either 10 above normal parameters or they're using accessory muscles, then that would be a 1, I'm sorry. Behavior, they're irritable, they're cranky, that's a 2. Cardiovascular, they're gray or cyanotic, or their capillary refill is greater than 4 seconds, or their heart rate is at least 20 above the normal heart rate for their age group. That would be a 2. Respiratory rate greater than 20 above normal parameters, or they have retractions. That would be a 2. 3s for behavior would be lethargic, confused, or reduced response to pain. That's a 3. Cardiovascular, gray or cyanotic, and they're mottled, or the capillary refill is greater than 5 seconds, or 5 seconds or above, or their heart rate is 30 or above normal, or they're bradycardic. That's 3. Respiratory rate greater than or equal to 5 below normal parameters with retractions or grunting. That's a 3. Okay, so you add these up, and of course this one's really nice. It gives you a little chart at the bottom with the heart rate and respiratory rates that are normal for the child at rest. Add those up, and then if the score is 0 to 2, you're good. You're golden. Kid, it doesn't necessarily mean the child doesn't need to go to the hospital, but it does mean the kid is not sick enough for you to be really scared or have to treat them in any way other than maybe transport. If they've got a score of 3, that's a yellow. This is a caution. You need to evaluate further, get in history, look at their oxygen saturations closely to see if they need oxygen, those type of things. 4, that's an orange. Now we're looking at they're more compromised. In this case, they may need oxygen. They may need ventilatory support possibly, or IV fluid support, or maybe a pharmacological intervention for something that has transpired, some toxicological situation. And red is 5 or greater. That's bad. They need support. They need resuscitation from you of some shape, form, or fashion. So this is a helpful score to help you determine just how critical a kid may be. So it's helpful to kind of keep this in mind, and it'll help guide your decision-making process. Partner trip. Other special resuscitation situations, just like with respiratory or pharmacological reasons or contributing factors to arrest, there are other situations in the pediatric subset that may need to be managed depending on the history, the outcome of the resuscitation measures, etc., other than those we've already discussed. Trauma. If based on the mechanism of injury or signs and symptoms there is possible cervical spine injury, do not routinely use the head tilt technique. Use jaw thrust only unless the airway cannot be opened adequately with the jaw thrust. And don't forget to pat or elevate under the torso to keep that head and neck in a neutral position. That will help keep the airway open. Do not routinely hyperventilate a pediatric patient, even in the event of a head injury. Now, you may try some intentional brief hyperventilation if there are signs and symptoms of brainstem herniation with a head injury, such as blown pupil or wide dilated pupils, unresponsive pupils, high blood pressure with a low pulse, coma and or rapid loss of consciousness, respiratory arrest, and trauma. Just temporary brief hyperventilation, but that would be the only time you might even consider it. In trauma to the chest or abdomen, keep a high index of suspicion for possible thoracic injuries, even if there's no visible bruising or signs of trauma. If the history's there, watch for it. Watch for signs and symptoms of developing or existing tension, pneumothorax, hemothorax, and be very highly alert for respiratory compromise. If they do develop signs of a tension pneumothorax, treat it immediately and aggressively with pleural decompression to improve the oxygenation, just like you would for an adult. If the patient has maxillofacial trauma, especially if you have to intubate them, consider placement of an oral gastric tube and stay away from nasogastric tubes and are the current recommendations. Consider the following possible causes of shock in the trauma patient: tension pneumothorax or tension hemothorax, intra-abdominal bleeding, pericardial tamponade, spinal cord injury, intracranial hemorrhage. Keep an eye on these kids. Watch them, assess them frequently, assess them thoroughly. During a resuscitation attempt, try to keep at least one family member with the patient. And I know when you get in the back of the ambulance, that makes it very hard. If you can allow the mother or the father to stay with the child for their own mental well-being and seeing that you're doing everything that you can possibly do, try to do that. But if it does create undue stress for the team or it's disruptive in any way, the family member should respectfully be asked to leave. If someone is not working on it's helpful to have that person stay with the family. Talk with the family and provide emotional support until more definitive assistance can be made. Termination of resuscitation efforts in children as to the when is controversial, highly emotional for many of you, even seasoned providers. So there should be adequate protocols in place in your department to help you make the decision of whether or not you can or should terminate in the field or go ahead and transport to a definitive care facility. In summary, dealing with pediatric emergencies is among the most stressful type of 911 calls you're going to face. Arming yourself and helping you to know what to use, when to use, and how much to use is done by completing not just this initial training, but maintaining your continuing education on pediatric emergencies. Taking PALS and other courses regularly is imperative in helping you to make the right selections, because the wrong selections can mean the difference between life and death for these patients. So stay up to date, keep yourself educated, and then these situations may not be quite as stressful when it comes time for you to deal with them. Thank you.